module of the trauma session. So today we are going to deal with polytrauma. The topic for the day is polytrauma. So why I am stressing on this polytrauma? Because polytrauma is one such area which is dealt in great stress, but just believe me that it would give you immense satisfaction when you do with a right approach. There you can make a difference for the patient's life, right? You can save a limb, you can save a life. So just miracles can happen with your approach, with your knowledge, and with your expertise, right? So let's just get into the great detail of polytrauma today, and let's understand few important topics, but pertaining to our orthopedics, okay? So polytrauma, starting with your definition, right? So definition is your poly and trauma. So it is a multiple injuries to the patient, right? So what could be those injuries? So first, it could be a major system involvement and with your long bone fracture, right? And then it could be two long bone fractures. That could be a polytrauma again, more than one long bone, right? And then it could be a pelvic bone fracture with any visceral injury. And then it could be your open injuries, mostly your grade 3 injuries plus any major system involvement, right? So these are some of the examples of the polytrauma where you have to deal with multiple systems. So dealing with multiple systems make you deal with so many members associated with it. So you have to deal with other specialty surgeons, you have to deal with other people with the same knowledge, right? So here you require a multidisciplinary approach, right? Everybody should have a universal protocol where this examination or this approach to the patient could be conducted smoothly. So this approach or this protocol has been given to us by the American College of Surgeons, and that protocol is called as your ATLS. So what is your ATLS? It is your Advanced Trauma Life Support, right? And how is that approach done? So by this time, you would have all known that the Advanced Trauma Life Support is designed with the basic alphabets, which you have learned right in your early years. So yes, this is the ATLS. As simple as that, A, B, C, D, and E, right? So you all know what is A, B, C, D, and E. It is written very clearly in that, but I just want to add certain adjuncts to each alphabet. So starting with A, as you all know, it is airway. And what I want to tell you is it is also associated with your cervical spine stabilization. And then coming to B, it is about breathing and ventilation, right? So you examine for the patient regarding breathing and you resuscitate. And C is again your circulation with your hemorrhage control. So you are controlling the hemorrhage here in C step. And then coming to the D, it is about disability the patient is having at this moment, and then your neurological status, right? And then last one is E. So E is for exposure. So you have to undress the patient completely, and then environment. So you have to put this patient in a warm environment so that he doesn't go into a lethal triad, which is associated with hypothermia, right? So that is about your ABCD. And before performing this ABCD, there should be one more protocol where you can deal even more smoothly with the patients so as to how to conduct this ABCDE, right? So you already know what is ABCD, and now let's see how to conduct this. So as soon as this patient enters the ER, so with multiple injuries, so you start away right from the starting, you do your ABCD approach. So you check for the airway, breathing, C, D, and E with your adjuncts. What are those adjuncts? So again, you go for your ECG, your chest X-ray, your pelvis X-ray, right? And your CO2 levels, and most importantly, your ABG. So these are some of the tests or parameters which help you to come to a diagnosis, right? Whether the patient is suffering with any of the life-threatening conditions. So this is called as primary survey. Primary survey. So as soon as the patient enters, you do a primary survey. So it is nothing but your ABCD along with your adjuncts, right? And then after your primary survey is done, the patient is stabilized. The patient is stabilized. And now you examine the patient in detail. That is called your secondary survey. Secondary survey is nothing but your tip-to-toe examination of the patient in detail, right? So once you are done with your primary survey and secondary survey, now you put the patient to your definitive care. Put the patient to your definitive care, right? So that is how you have to put a protocol in your emergency room and do it accordingly so that everybody is in pace with you, and all these specialist doctors can come to a conclusion and give a best possible approach to the patient, right? So now let's see this in a flow chart. So here is the patient who comes with the injury, right? And then you're conducting your primary survey with your adjuncts, right? And then you resuscitate. So this is very, very, very important. Whatever you're doing, the surveys should go in hand with your resuscitation, right? And then you re-evaluate it again. And then again, you resuscitate. So once you're pretty sure that the patient is stabilized, then you go for your secondary survey, right? And then you put, finally, you put the patient in your definitive care. So for example, if the patient is suffering with fracture femur with the head injury, so after doing a survey, you do a CT scan of the head, right? And then if it is a normal scan, then you re-evaluate your femur fracture. And then if the patient is not having any other signs of, shock or any other signs where the patient is deteriorating and you feel that he's stable, then you shift him to your orthopedics department to treat the fracture condition. So that is the definitive care. So this is the protocol you have to follow. And coming to this A, B, C, D, E, each one. So in airway, you see about the obstruction. So obstruction in and around your mouth and nose, where the air entry is hampered. So you make yourself pretty sure that there are no hampering of your air obstructions, and then simultaneously you will stabilize the C-spine. That you do with your hot color, and until and unless proved, all these injuries should be taken as the spinal injuries, and you follow your log roll method for transferring the patient. Right? That is, log roll is nothing but you put the patient on the bed and simultaneously the torso and the limbs and the head should turn. So that is the log roll method. And then coming to the breathing. So here you're concerned, once you establish the obstructions is relieved and when you're pretty sure that air is entering into the lungs, you should make sure that exchange of gases is taking place. So if that is hampered, then you have to go for ventilation. So you have to look for any chest injuries which will hamper your ventilation, right? So some of the examples could be your tension pneumothorax, your cardiac tamponade. So all such life-threatening conditions should be looked for. And then appropriate measures such as ventilation, like your intubation, should be taken care. Then coming to the utmost important one is your circulation, which is important for us. So this could be hampered because of loss of blood. So you have to take the hemorrhage control, and simultaneously you have to resuscitate this patient with IV fluids, fluid replacement, and ultimately with the blood and the blood products, right? So that is how you treat your loss of fluids, right? Then comes your disability. So disability is taken care with your neurological examination, and this neurological examination can be quantified. So this is given by your important Glasgow Coma Scale. So here in this Glasgow Coma Scale, you have a mnemonic which is E4, V5, and M6. That means eye opening is 4, verbal response is 5, and your motor response is 6. So this is how you have to remember. And the best score is 15. 3 is minimum because there is no 0, and less than 8 or 8 is your coma. So based on that, you evaluate your neurological status of the particular patient. You take the help of this very important Glasgow Coma Scale, right? You have to by heart this table, the Glasgow Coma Scale, right? And then there is E, which is regarding your exposure. So coming to this exposure, I've already mentioned that you undress the patient completely. So any obstructions or by your dress or your clothing or your ornaments, everything is removed. And then you put this patient in a warm environment to escape the lethal triad, which is hypothermia, coagulopathy, right? So hypothermia is one of the component of this lethal triad. And then to escape this, always put the patient in a warm environment. To that context, you can also transfuse warm fluids to just escape this patient from hypothermia, right? So this is hypothermia in your exposure and environment. So that is how you deal with your A, B, C, D, and E, right? And now coming to the next concept. So once you have done your primary survey, your secondary survey, everything is done, right? Now let's think that our patient is somewhat normal, stabilized up to your secondary survey, because all these are dealt in great detail by your other department professors. So now in context with orthopedics, I want to deal with the 2 important concepts for definitive care in orthopedics. So coming to this definitive care. So once let's imagine that whoever has entered this patient, he's stabilized by primary, secondary and all, and now they are transferred to you. And now in this patient, just imagine there is a patient with femur fracture, some 25 years old, right? And with head injury and a liver laceration, right? And then there is one more patient, femur fracture, same 25 years old, with the tibia shaft fracture, with the head injury, right? And foot laceration. So this is a scenario of patient 1, and this is patient 2. So there are 2 patients. They think they both are brothers riding on the bike. So one is sitting in the front, the other is sitting behind, and one has sustained femur fracture, and this is shaft. Let us assume this is a shaft fracture, both shaft fractures, and the first one is having head and liver. So you have taken consent from the neurology, and he has advised for CT scan. So you sent him for CT scan, and you see that it is normal, right? And then you have consulted the general surgeon. So for the liver laceration, and he tells it's a conservative treatment. So now your patient is transferred to you. So here this patient comes to your ortho department. So for the definitive care. And here similarly, there is a similar patient with head injury. So his CT scan. So there is some abnormality, but still the neurosurgeon will tell it is conservative, putting him on some drugs, right? And here the femur, the tibia, and now this patient has a loss of blood and he is in shock, right? Let us assume he is in some grade 2 shock, right? So now that this patient has been resuscitated because of grade 2, he has been put on fluids, blood and all, and then he's been transferred to your department again, ortho. Because clearance has come from the neurology and the other 3 are from your department. So you have been clear, he has been transferred to your ortho. Now in this first patient, what will you do? The treatment for the first patient. So here, because he is a 25-year-old femur shaft fracture, you first rule out the important shock because of loss of blood supply. Then the second one is your fat embolism syndrome, right? So these two you rule out first. And if you say these two are normal, so there are no signs of any evidence of shock or your fat embolism syndrome, and then you take this for surgical fixation. Take this patient for surgical fixation. So you have fixed him with your intramedullary interlocking nail, and this is done by some. So next day, you have taken him the next day. So he has come somewhere around evening 6. So by morning 6, this nailing has been done. So within 24 hours, he has been treated, right? So within 24 hours, all his problems have been addressed, right? So now, coming to the next patient. So in the next patient here, he's with femur shaft fracture, tibia fracture, then he has head injury and foot laceration. So now head injury clearance is given from the neurology department, and that is he has put him on some drugs and he have transferred to you. And here this is an open injury on evaluation. You see an open injury of tibia because tibia is more prone for your open injury. So here there is an open injury of tibia with the femur shaft fracture, and then you have your foot laceration there on the dorsal aspect, and then you have your shock. So these are all the components which you have to deal with. So here already the patient is suffering with some trauma. We'll call this as your first hit. So he has been suffering with some abnormality inside. So there is an open injury, there will chance of infection, then there is shock, and then there's a foot laceration, again a chance of your infection and femur shaft, there will be a loss of blood, and then patient is in shock. So here already he's suffering some from injury. And for this patient, what will you do? Here, this patient, you treat him, take him to the OT, but you don't put intramedullary interlocking nail, but you treat him with X-fix plus debridement, right? And then primary skin suturing for the foot. Right? And then you treat the patient with the shock. So here you're not doing a definitive care. What is a definitive care? It is the interlocking nail or plate, right? Where that is the end treatment for the patient for that particular fracture. But here you're putting a temporary. This is a temporary measure. That is, you're putting X-fix. You will put something like you're spanning or bridging X-fix from the femur to the knee. Or if the femur shaft and tibia are separate, you put separate X-fix for femur, separate X-fix for knee. So you're taking some time for a definitive fixation. So this is called your damage control orthopedics. So this is called your damage control orthopedics. So what is your damage control orthopedics? So coming to damage control orthopedics. So this is your damage control orthopedics. So here what had happened? So first hit, there is a first hit, that is the injury itself is the first hit, right? And now you don't want your patient again to hit by second hit. That is your surgical stress. That is your surgical stress. When the patient is given a surgical stress, he might land up in complications. So now you take some time and give time to that patient to recover from the complications which he has been suffering. That is your shock or the fracture pattern, right? The shock or open injury, the fracture, whatever is that. So first you control the patient metabolic conditions, you treat the other aspects of the patient, and then you come to your definitive fixation at a later date. So this is called your damage control orthopedics, where a temporary intervention is planned first, and then patient will go to definitive fixations, right? So this is a damage control orthopedics, similarly like your damage control surgery. So what is required? The minimum requirement is provide. The minimum requirement here is to stabilize the fracture. So we have stabilized it with X-fix, and then the open injury should be debrided. So we have debrided it, right? And then the laceration, if it is permitting to close, we will close them with primary skin suturing. So this is the minimum which can do to the patient. So that minimum we have done. But here we have completed the definitive fixation within 24 to 48 hours, and this is called your early total care. So what are the advantages of early total care and advantages of damage control surgery? In case of early total care, mainly you can mobilize the patient with your definitive fixation. So the nursing care will be improved. So there will be decreased complications because of your patient being bedridden, your pulmonary, your ventilation and perfusion ratios will be lost once the patient is bedridden, right? So you can encourage the patient to get mobilized. So that is your early total care. And whereas your damage control orthopedics, because the patient is already compromised, you don't want to give the second hit injury to hit. So avoiding the second hit, you take some time for the recovery of the patient and then go for your definitive fixations. So that is your ETO and your damage control orthopedics. So now coming to some of the few complications of this polytrauma. So polytrauma complications. Right? So here, first and foremost is your shock. And then there is fat embolism syndrome, which we have to deal. And then there is crush syndrome. Right? So these are some of the important complications which I want to go into the great detail from the complications of the trauma, right? Especially polytrauma. Coming to the shock. So what is the shock? Definition of shock is nothing but it is a global hypoperfusion, right? It is a global hypoperfusion where the effective circulating volume is decreased, is compromised, which will result in decreased end organ supply of oxygen. So because of decrease in the volume of the blood, the oxygenation to the tissues, the end organs is decreased, and then these organs are at a risk of developing ischemia or necrosis, right? So that is the definition of shock. So why? What are the causes for this shock? The first and foremost important cause which I want you to remember is your hypovolemic shock. So this is the most common and the important cause from our department, right? From the Department of Orthopedics. So shock would be the most common cause, and this is the loss of blood. That is your hypovolemic shock is the most common. And coming to the shock, it can be divided into, there are various shocks, right? It can be divided into vasoconstrictive and vasodilative. Depending upon this, you can divide the types of shock. So in the vasoconstrictive, the first one is your hypovolemic shock because of loss of blood supply. Because of loss of volume, so the loss of blood and loss of volume, the vessels go into vasoconstriction, so it is a hypovolemic shock, the first one. The second one is your obstructive, because of any obstruction, right? And the third one is your cardiogenic. So these are the types of shocks. And then coming to the vasodilative, there are other three. The first one is your septic shock, second one is your neurogenic shock, and the third one is your anaphylactic shock. Right? So these are certain shocks which you have to be familiar with. So you have to diagnose what type of shock is the patient suffering from, and hence will be his treatment. So for that, you have to identify. And I'm telling you, the most common shock here is the hypovolemic shock, where because of the loss of the blood or loss of the fluids, the patient will result in this hypovolemia. Right? And coming to the obstruction, this obstruction could be any obstruction, right, from your cardiac tamponade, your tension pneumothorax, all these obstructive causes. And cardiogenic is mainly because of fail of your cardiac failure. So directly the heart is not able to pump the blood. And what is the most important thing for here again for us is your neurogenic shock. So this neurogenic shock could be because of the spinal trauma, where there is a loss of sympathetic outflow, and which will cause loss of the tone of the vessels, and then they become dilated. So now you can feel the warm limbs with hypotension and bradycardia. So this is very, very important. The patient presents with hypotension and bradycardia in case of neurogenic shock with the warm limbs. So here the treatment remains the inotropic support, right, for the neurogenic shock. This is different from the spinal shock, right? The spinal shock is entirely different. This is the neurogenic shock which I'm talking about, and the treatment here. And the treatment for your hypovolemia. So here you treat the patient with replacement of fluids with your IV cannula. That could be a 15 or 16 gauge needle, and ultimately you plan for blood transfusions if the fluid loss or the blood loss is more, right? And in case of your replacement of the fluids, it's mainly your ringalactate which should be used. And then you monitor this shock. This shock is divided into 5 classes from grade 1 to 4. 4 classes of shock is there, and based upon your urine output, your pulse rate, your BP, your neurological status, this grades has been given and you treat them accordingly. So this is about the shock, and this will be dealt in a great detail in general surgery also, so I'm just escaping from that, right? So next is your fat embolism. So this is our major concern from our department. So this is fat embolism. So what is a fat embolism? This is nothing but the systemic manifestations with the fat globules of more than 10 microns in microcirculation. So this could be your definition, where because of this escape of the fat globules into the blood or ultimately into your microcirculation will produce the systemic manifestations. That is called your fat embolism. So why does this occur? This is mainly because of injury to the long bones, where there is a medulla inside and which is made up of fat, right? So fat is present in the medulla, and when this long bone fracture will release these fat globules into the circulation, right? They release these fat globules into the circulation. So once these fat globules are released into the circulation, this can be forming the fatty acids by the enzymes lipases, or this can present as fat emboli, right? When they act as fatty acids, they result in vasculitis, causing this systemic inflammatory response. So there is a systemic inflammatory response because of this fatty acids which are causing this vasculitis, right? And this fat emboli can cause the obstruction of the capillaries and resulting in the symptoms, right? So ultimately, whatever happens is the manifestations which are important for us. So this is the theory regarding the fracture, and most common fracture is your femur, and mainly in your young individuals. This is what you have to remember. So whenever they frame a question regarding a fat embolism, they usually start with a young individual with femur fracture. So that is how the prototype for fat embolism questions would be. So you have to remember the most common is femur, and it is mainly seen in the young individuals, right? So young male patients. And this is the theory behind your fat embolism syndrome. So how do they manifest? So what are the systemic manifestations which I have told you? So the systemic manifestations, they involve in 4 different systems. So first, starting with your neurological system, and then your important respiratory system, and then your cutaneous skin manifestations, and then your retinal manifestations. So these are your 4 systems which are involved in fat embolism, and they produce a variety of symptoms based on this. So coming to the neurology, they produce with confusion, altered sensorium, right? And then respiratory is the respiratory distress itself. And cutaneous is very pathognomic, they produce with the petechial rash around the axilla, right? And retinal is in terms of retinal hemorrhages. Retinal hemorrhages, they produce the symptoms. So always remember the triad. There is a triad of fat embolism. So first there will be a fracture of a long bone. Then the patient will produce with respiratory distress and neurology. That is your confusion, altered sensorium, and petechial rash. So whenever you see this triad of symptoms with the fracture femur in a young, your answer 99.9% will be fat embolism. Right? So this is very, very important topic regarding your orthopedics, and it is usually frequently asked question. So that is why I'm going in great detail in it, right? So this is the manifestations, the systemic manifestations with which your fat embolism will present with. And how do you diagnose it? So coming to the diagnosis, so first the patient presents with the hypoxia. So that is nothing but your respiratory distress. Then he might present with tachypnea, tachycardia, temperature, right? So these are certain symptoms, confusion, and ultimately with your petechial rash, right? How you come to a diagnosis? So you can use the chest x-ray where you see something which is very misleading, ARDS like picture always. So usually coming to the chest x-ray, you will see ARDS like picture. That is why it is very misleading to make the diagnosis. But there is something called your Gertz criteria, which will help you. The Gertz criteria, which will help you for the diagnosis. So what is the Gertz criteria? It is the triad of symptoms which I have already told you, the respiratory distress one, the neurological symptoms in a non-traumatic patients, and the third one is your rash. So these 3 are present with Gertz. That is considered as your major criteria. And you have certain minor criteria. So minor criteria are temperature, that is your fever. And then you have tachy. And then there is thrombocytopenia, right? And then there is anemia, jaundice, right? And then there is renal changes, and there are retinal changes, and then there is raised ESR. And this Gertz criteria also considers presence of your fat globules in urine, right? Fat globules in the urine. So these are certain criteria, or major and minor, at least 1 major or 4 minor, they should be present to conclude it as your fat embolism syndrome. So that is how you come to the conclusion. Then you go for the treatment of your fat embolism. Treatment is, to your surprise, the patient has to be taken to fixation. So there are various theories or articles which are proving that this patient with fat embolism syndrome, when treated with definitive fixations, have done well, right? So you have to consider this option of fixing the bones. For example, if the patient is suffering from fracture shaft femur, then you can take the patient for the surgery, fixing him with nail, and this surgery should be done as quick as possible. So quick in and quick out type of surgeries, and then the patient returns back to his normal, because this definitive fixation will definitely improve his ventilation perfusion mismatch. So there are increase in the ventilation perfusion rates because there is an increase in the nursing care. The patient can be able to sit, and then you can do chest physiotherapy, you can do mobilization of the patient, so that all these symptoms will come down. So before that, you have to start with anticoagulants. And then you can go with your corticosteroids, because I've already mentioned some inflammation is present, and then your oxygen therapy for hypoxia. So these are some of the adjunct treatments, and you go for your supportive therapy. Right? So this is some of the important treatment regarding your fat embolism. But remember, the definitive fixation should be considered as one of the important options for treating fat embolism syndrome, right? So this is about the fat embolism syndrome. Next coming to the one more important complication, that is your crush syndrome. So what is this crush syndrome? Crush syndrome is nothing but a combination of crush injury plus your compartment syndrome. Right? So in case of crush injury, what is this crush injury? So whenever there is any limb which has been entrapped in a machine or in a vehicle during the accident, or it could be occurring during the earthquakes, where a huge heavy object falling on your limb, that is called crush, right? Crushing, which will cause crushing of your limbs, right? So there will be an injury first, right? So whenever there is an injury, this will result in loss of blood supply. right? So because of your crushing effect, so there is a huge weight on your limb. For example, take an example of your lower limb. So just think that there was a patient who was resuscitated from the earthquake, right? Before resuscitating, they give a history that there was a huge pillar fell on his limb, and now he has brought to the hospital. Now let's see what will happen to this patient. So now during that injury, during that pillar falling on his limb would result in the crush injury, right? And this injury will cause ischemia because of some heavy obstruction, and this ischemia will do two things. So first, ischemia, what will it do? It will cause myonecrosis. So the myocytes will be dying there, and the cell will be disintegrated. So when the cells are dying, this will call accumulation of that cell products. So whatever these products are present, or whatever the contents of that myocyte will get accumulated. So what are those accumulated products? So there will be potassium in the muscle, there will be myoglobin in the muscle, right? And then there will be CK, creatine kinase, and then there will be LDH, your lactic dehydrogenase. So these are certain components of the muscle, and as soon as the cell disintegrates, the myocyte disintegrates, there will be accumulation of these products. And similarly, this ischemia will also impair the microcirculation, right? Microcirculation is impaired. So this will result in fluid accumulation because of the pressure, because of some abnormality in your sodium. The fluid accumulation will occur. So this will increase the tension. So because these muscles are arranged in compartments, as you already know, with help of your tight fascia. So there is a fascia in each compartment. So these are encircled by the tight fascia. So this will result in compartment syndrome. So at one end there will be compartment syndrome, and at the other end there will be accumulation of these products. So this is what is occurring there. And now suddenly this patient is resuscitated and is brought to the ER. So on the while he's getting, now because of this heavy object is removed, there will be reperfusion, right? So now again the blood vessels will try to enter, because that whatever the obstruction, the heaviness is will removed. And this is not very good because there is a reperfusion injury which will release oxygen free radicals. So sudden removal of this obstruction will cause this reperfusion injury. And similarly, as the vessel is entering into the circulation, there will be release of these contents like your potassium, your myoglobin, your CK, your LDH will all get released into the circulation, right? And now this will manifest as your hyperkalemia, right? Then myoglobinemia, right? Acidosis and hypocalcemia. So because of the acidosis and your various metabolic changes, there will be hypocalcemia, and this myoglobinemia will enter into the kidneys. So they get excreted, and this will result as myoglobinuria. So presence of this in the urine is myoglobinuria, presenting of myoglobin in the blood is myoglobinemia. So as they enter into the kidneys, there is a urea, everything is happy till now, but the kidneys will raise the threshold. So it will reach the threshold where it can't take that myoglobin, because it is a huge muscles, right? So there is a crush injury of the entire compartments. If there is a heavy object falling on your leg, there is anterior, posterior, lateral compartments with so many muscles, right? So these muscles, so much of myoglobin, the kidney is unable to take that much of threshold. So what it will do? So this will result in loss of tubules. So the kidney will tell, I am dead. Renal tubular acidosis, RTA. So the kidney will just tell that I can't take enough of myoglobin and now I am dead. So kidney is not functioning now. So this will again increase the trauma to the patient, right? So now, how does the patient presents with? So you already have so many components here. So the patient will present now with your fever, severe pain, tachy, and sometimes they may present with rashes. And because of this cola-colored urine, right? And because of this potassium, they might present with arrhythmias also. Right, and this is all the scenario which is happening here. That is the crush syndrome. So whenever this kidney is been lost, this is nothing but your crush syndrome. The kidney has been affected with all these features of hyperkalemia, hypocalcemia, acidosis, and myoglobinemia. Right, and how do you treat it? Treatment is again fluid resuscitation. So you keep the kidneys as much as hydrated. So you send lot amount of fluid so that kidneys functioning smoothly, sending off the myoglobin completely. And you do alkalinization of urine. That is forced diuresis, and ultimately you can deal with dialysis. So all this, whatever this is present in the systemic circulation, is excreted to the kidney. So that is the treatment of the crush syndrome. So you have to be aware of the crush syndrome. So this might be some of the complication which might damage your kidneys, and ultimately this might hamper the patient's life. So this is one of the important complication, right? And so now completing the complications. So there are other complications such as your MODS, where your multi-organ dysfunction, which will result in CIRS, where is this inflammatory syndrome. So these are other complications of the polytrauma. So this is dealt in detail again with your surgery, right? Now coming to one more aspect of the polytrauma, that is the open injuries. If you remember, during the definition, I've already told you that this open injury of grade 3 is included as a polytrauma when associated with the visceral injury. So what are these open injuries? So open injury is defined as when a fracture hematoma getting exposed to the environment. Right, so the fracture hematoma. So there is a fracture, and this fracture hematoma is getting exposed to the environment. That is called the definition of open injury. So this fracture will create a defect in skin or the soft tissue. Right, so through this defect there is the communication. So this defect necessarily would not be on the fracture site. It could be away from the fracture site. Still it can communicate, hence the open injuries. Like even if the defect is not in and around the fracture site, it is little proximal, little distal, also you should still consider them as your open injuries. Why are we dealing with open injuries? Because these could be life threatening injuries and again require a multidisciplinary approach. So hence the name orthoplastic. So usually your open injuries are dealt with your surgeon, orthopedic surgeon, and a plastic surgeon. So because of the wound covers, because of the loss of the cover over the bone is given by your plastic surgeon, this is called an orthoplastic approach, right? So that is about the open injuries. And then similarly, this is treated as a polytrauma where you start your resuscitation with A, B, C, D, and E. And finally, if the patient is stabilized, you do this definitive care for open injury. Right, so we are done with the resuscitation. So any open injury should start again with the primary survey of A, B, C, D, E, and then you come to the secondary survey. And once the patient is stabilized, you shift to ortho for the definitive care. So these open injuries, first you start with the classification, and then you deal with the treatment principles. Right. So what is the main complication of the open injuries? So it is infection. So you have to deal with the infection. So as soon as you see an open injury, you should start your antibiotics, right? And then your resuscitation. So these two should go hand in hand, and then you evaluate your open injuries by the classification systems. So there are various classification systems which have been designed, and the important one is your Gustello-Anderson's classification system, right? Where this is mainly based upon the wound size, right? And the contamination. So this is the Gustello-Anderson classification for open injuries, where it is mainly depending upon the wound size. Then you have MES score, which is called Mangled Extremity Syndrome, right? Mangled Extremity Syndrome. Mangled Extremity Severity Score, not Mangled Extremity Syndrome. It is Mangled Extremity Severity Score. Okay, now and then there is one more classification which is called as the Ganga Hospital Trauma Scoring. So as have you seen Ganga? It is from the South India, Tamil Nadu. There is a Ganga hospitals at Coimbatore, and this is given by our own Indian Dr. Rajashekaran, and this has been accepted as a scoring system for traumatic open injuries, and this is one of the most important scoring to decide between amputation and limb salvage. So this has been accepted internationally, right? Given by our Indian to a South Indian by the Ganga hospitals at Coimbatore, right? And now coming to the, so I have already told you that one of the main thing about this open injuries is infections, right? But what are we much worried about? So in case of open injuries, our concern is mainly between amputation and limb salvage, right? So your very concern is between amputation and limb salvage. So for this, there are various scoring and grading systems. So to decide whether this limb is going to amputation or salvage procedures is based upon this scoring systems, because during this open injuries, there will be a lot of bone loss, a lot of viable tissue, a lot of tissue loss, and a lot of nerves, vessels, tendons, and a lot more injuries to the patient. So based upon this, you have to assess where you can really salvage the limb, which would be beneficial to the patient, or you can go for amputation, right? So for this, the scoring systems have been given. So most important, according to the exam point of view, is your Gustello-Anderson classification system for the open injuries. And if, I'll be very happy if you remember this message score. This is just an extra information, right? This Ganga scoring is just an information, right? So now let's start with the Gustello-Anderson classification. So as I've already told you, the Gustello-Anderson is mainly based upon the wound size. So this is divided into type 1, type 2, type 3, A, B, and C. So when I say type 1, that means the wound size would be somewhere around 1 centimeter. And type 2, it weighs somewhere around more than 1 to 10, and type 3 is more than 10 centimeters wound size. So based upon this size, at least you can just tell that this is type 1, type 2, type 3 fractures. And coming to the soft tissue, there will be only a minimum damage to the soft tissue where you can get off with the definitive fixations, right? And coming to the type T, there is a moderate soft tissue damage. Still, you can treat them, okay? But coming to 3A, B, and C. In A, there will be high injury to the soft tissue, but you can manage. But here in type B, you require reconstructive procedures like your flap, or grafting, right? And type 3C is associated with the vascular injury. So what you have to remember here is the trick here is any vascular injury is directly graded as type 3C. If the patient is requiring plastic surgery, then you go for 3B. If it is more than 10 centimeters with no plastic intervention or no vascular, then you go for 3A. If it is somewhere between 1 to 10, 2 and less than 1 is 1. So that is, it is simple, right, to remember. And bony injury also, this will be minimal comminution. Minimal comminution. This is moderate comminution. And this is severe with bone loss, right? And contamination is minimum again, moderate and very high contamination. So that is the Gustilo-Anderson classification. So the important point for you is 3C, straight away to vascular. If the patient in the question, if he is requiring some orthoplastic approach, like he's been treated with the flap or graft or any reconstruction procedure for the soft tissue, then you go for 3B, right? And 3A is a high injury that is more than 10 centimeters where there is a soft tissue damage, but you can still manage it with the primary treatment, like your suturing of the skin, the primary skin suturing, right? So this is about the Gustilo-Anderson classification. And then we'll go for Mangle Extremity Severity Scoring System, that is MES. So in this MES, you can remember this as ELISA. So E is energy, LI is limb ischemia, and then your S is for shock, and then A is for age. So this is ELISA, where you have to remember the energy, the limb ischemia, the shock, and the age, and this is the scoring system which is given here. So based upon this scores, you can go whether you can put the limb to amputation or to limb salvage. So right, so that is how the scoring systems are helpful. So the MES, the Ganga, and the open injury, the Gustilo-Anderson classifications. Now coming to the type of Gustilo-Anderson classification, starting with type 1. This is type 1, where the wound is less than 1 centimeter and the bone is minimal comminution, right? So this is minimal comminution. And here, what would be the treatment? You can just go with the definitive fixation with the proper antibiotics to prevent the infection of the bone. So that is the treatment for your type 1, where you can go directly for the nailing for this procedure, right? So you're not worried about your injury because this is negligible. And coming to type 2. Type 2 is where the wound is more than 1 but less than 10 centimeters, right? Less than 10 centimeters. And you can see there is some amount of comminution. Some amount of comminution in the bone. And this part of type 2 can be treated without the plastic surgery, right? With minimum suturing techniques. So this is type 2. And now coming to type 3A. So in type 3A, there is a wound which is more than 10 centimeters. And here the bone injury is also high because it is the product of a high velocity injuries, right? High velocity injuries will produce this type of type 3A. And in this, if you see the bone, there is a segmental femur fracture. So this is the indication of high velocity injury. And in this case, this laceration, you can debride it. And you can still go for a primary skin suturing. So debridement with primary skin suturing can be the treatment for this. And you can go for a simple skin graft technique. Simple skin graft technique. So this is type 3A, right? And coming to 3B. So if you see, this is type 3B. So here there is a wound on the medial aspect. And after debridement, this cannot be closed with the simple suturing. So here you require a flap or a graft. Right? So flap or graft by a plastic surgeon in this wound after debridement is nothing but your 3B, type 3B. And if you see the bone here, there is a variable amount of comminution, right? And this bone should be fixed with some K-wire. And then you go with the flap, right? And then this is type 3C, where there is a vascular component. So there is a vascular injury. So hence it is named as 3C. So here the high velocity injuries you can see in this particular X-ray. So the bone is completely shattered here. So the bone is completely shattered and there is a huge amount of soft tissue damage. And you can see the limb is almost like nothing can be salvaged here. So it looks like it goes to amputation. This is a recent case in our ER. So this was very recent, just some days ago. So some days ago, this patient is a young patient of some around 32 years. And he has come with this open type of injury where there were pulses but very feeble, and we have gone for an amputation, right? So usually these vascular injuries will result in amputation, right? So what is the treatment for this X-fix? What is the treatment for this vascular injuries? So here are some signs for the vascular injury which you have to remember. So there are certain hard signs and there are certain associated signs. So hard signs is you will find a significant difference in pulsations when compared to the opposite side. So usually if you see the previous example, there were loss of pulses in the injured limb and there were pulses which are very good in the opposite. So there is a significant difference which is present, and there will be severe hemorrhage from the wound, and there will be, if at all there is a closed component, there will be some pulsatile hematoma, right? And you can feel the bruit or the thrill. And what are they associated? Associated, they present with numbness, they present with neurological deficit and skin temperatures. These will become cold and clammy, right? Because of loss of blood, vasodilation, they become cold, and there will be absence of venous filling, and there will be no pulses, no recordings on your pulse oximetry, and the capillary blanching is absent, right? So how do you treat with this open injuries? So usually the treatment of open injuries is your external fixator. So there are certain types of external fixator where you will first stabilize the bone for proper wound cover. So the bone component is dealt first, then your soft tissue component. So usually the protocol for treatment of your external injuries, first you have to go with antibiotics, right? A good amount of antibiotics. Then you go with debridement of the wound plus lavage. This is very, very, very important step. You have to debride thoroughly the wound, and then you go for skeletal stabilization with the help of X-fix. As I've told you, stabilize the bone first, and over it you go for wound cover or soft tissue reconstruction. So there are various types of X-fix. If you see, these are made up of tubular component. So there are two rods and there are Schanz pins, right? So these are the Schanz pins which you can see. So let me show the Schanz pins. So these are the pins which we put into the bone, and these are connected by the rods and the clamps to these tubes. These are the tubes. So this will provide the stabilization to the bone, and over that you try to put the flap. So for this is the recent, again we have done this. So the X-fix has been done, and over that we have done the grafting, right? So this is the grafting. This is the graft which you can see here. So this is the flap. So flap is nothing but which is present with this own blood supply, right? That is the flap. And this is the graft. Only the epidermis of the skin is the epidermis and dermis of the skin is your graft. Upper layers of the skin, right? And how do these grafts survive? They grafts survive with imbibition. So they take the nutrients by imbibition and they survive. And flap, because of their own vessel supply, because of their own vascular supply, they survive. So that is about the flap. And ultimately, if you can't rescue with the graft or flap, your X-fix, you go for amputation. So amputation is one of the important part of treatment of the open injuries. Right, so that is why a systemic approach, a proper approach, can sometimes save a limb. So if you identify them as like your crash syndrome or your fat embolism, you can save a life. So that is how the learning in detail about the polytrauma is important. So that's it. It is the end of the polytrauma. Then we'll meet in one more session. Thank you.